Welcome, everyone. Really happy to have you here for the first session of our Implementation Science Seminar Series this fall. And I'm really happy to kick it off with Dr. Kate Rendle. We are going to, just to let you know, with her permission, we are going to record this because not everyone was able to make it, and we'll be sharing this on our YouTube channel. So just wanted to let everyone know that. So I want to welcome Kate, who is going to be speaking on this issue that is very near and dear to my heart of de-implementation of cancer screening. We also have a funded project in this area, and we are realizing how challenging this is. And she's really going to be speaking about this intersection of implementation and de-implementation in the context of cancer screening. A little bit about Kate. So Dr. Rendle is an associate professor with tenure in the Department of Family Medicine and Community Health at the University of Pennsylvania's Perelman School of Medicine. She's deputy director of the Penn Center for Cancer Care Innovation at Abramson Cancer Center, and she also directs the Cancer Implementation Research Program at the Penn Implementation Science Center. She leads a robust portfolio of NIH-funded research, a P50, an R01, a U01, that brings together diverse qualitative and quantitative methods to improve the quality, equity, and implementation of cancer care delivery. And a lot of her work focuses on both lung cancer screening and cervical cancer screening in both the United States and Botswana. Her training and background are in anthropology and social work, and she also has a degree in epidemiology. I have been very lucky to work with Kate. We have co-led the Health Equity Methods Core for the Penn Implementation Science Center, which has been amazing. So I'm really excited for Kate to join us today and for us to learn from her. So welcome.
Awesome. Thank you so much for having me, Rachel, and for everyone for joining. And as of October 1, I'm now the director of PC3I. And so, yeah, so it's exciting, also challenging to figure out how to do all this stuff. But our founding director, Justin Buckelman, has left to do more new adventures. So I've stepped into the reins. So, all right. So today I'm really going to talk about, I'm going to set you up on all the work I did to set up this we did to really set this up, because we knew from the start, and the field knows, I think, from the start, that de-implementation is hard, right? It's conceptually hard. It's hard from an action. It's also hard because you're stopping things rather than starting things, which when you stop things, there's just if they've been continued, there's some inertia, right? Where starting, you have to push them. Stopping them can be quite challenging. And I just, maybe just to briefly, Rachel, or the group, level of sort of knowledge of implementation science language in general, is it sort of, I can try to explain words as I go along, but I didn't know if this group was more savvy with some of the nuances of what we say in the field, or if I should sort of make sure that I'm clarifying along the way.
I think it's a range, but I think many people that I see on the call today have a foundational or even more than that level.
Okay, perfect. So if I say anything that is like, what is that word? Please, anyone interrupt at any time, put it in the chat or raise your hand and just say, you're losing us, because we don't know what that is. But I'll try to sort of operate as a higher level of understanding of what implementation science is. And of course, what de-implementation science is. It's not just stopping, right? It can be replacement, substitution, removal. There's different approaches in which you're doing it. But basically, you want somebody to stop doing or reducing the thing that they were doing and change it with something else, or completely remove it from their practice in general. Okay, so I'm going to set up, as I said, sort of the cervical cancer screening and making the case for de-implementation. And I really do think that you do have to make a strong rationale and case for de-implementing and what used to be, in most cases, an evidence-based practice. While there may be some things in practice that were never built on evidence, most often, if they've continued, there's a reason that people are doing it, right? And so even at that basis, you have to have a sort of a rationale and a case for why you're doing it. Then I'm going to talk to you about where we started and how it's going, and really some of the unlearning and learning, and then lead you to where we are, which is we think we know our next steps, but we're not even sure with that. So really welcome sort of thoughts and feedbacks and sort of larger implications for the field of de-implementation science. So cervical cancer, sort of just highest level, We've moved from a very blunt instrument to more nuanced or targeted, but it is still a population-based screening that actually has been quite successful. So this is just the distribution of HPV associated. So that's the primary cause, and it probably is associated with all cervical cancers. We just can't necessarily detect, but the vast, vast majority are caused by HPV. There are, of course, other cancers that are associated with HPV that actually aren't declining. I'm not going to talk about those today, but this is a virus that's associated with this cancer. So the good news, it's good and bad news. In the United States, we'll have about 4,300 deaths this year estimated from cervical cancer. Which all of these are likely preventable. So that number we really need to get to zero. But when you consider it at the global perspective, which I do work in cervical cancer in sub-Saharan Africa, we are doing much better, where the vast majority of these cases, over 350,000 deaths each year from cervical cancer, the vast majority are in low and middle income countries, and a vast majority of those are in sub-Saharan in African countries. So more work to do there, but we have made a lot of progress in the United States. And this is partly because we have many, many different strategies in which we've deployed. So this is just from the start of the general population approach to cervical cancer screening, the reduction of over 50% and maybe greater now in deaths since we started doing routine screening. We've used different strategies and tools. But what you still see is that there is still a disparity, and you can add other groups. This just looks at white and Black females, that while we've all gone down overall, this, of course, the inequities have persisted. As I noted, this is just not one thing, right? We didn't just do one thing to stand this up, right? There's been, in the light blue, it's been in development of actually primary prevention through our HPV vaccine. We've had changes in the guidelines by which we assign like the actual cellular risks and naming that we use when we're saying that this one is high risk, this is low risk, and what happens next. And we've also gotten better in our screening technology. So the actual the PAP that started is not the PAP we use now, and we've used new technologies with primary HPV testing, and then primary HPV testing most recently. Not surprising, as all these changes have occurred, there's been many changes in the guidelines, and so there are many females, and I'll use the word females to sort of indicate anyone living with the cervix in my talk. But that there are women alive and well that are screening now that were around when this started. So they've actually experientially sort of felt all of these changes. And so we've gone from, PAP tests to annual tests, just starting at 18 to then 21, and then extended guidelines. And then now more recently, we have more risk-based approach, at least with the follow-up and with primary HPV testing. So not surprising, right? With all these changes, we might understand why there may be resistance to some change or just a delay in some change in these evidence. But the most recent guidelines right now, as of 2012, there was consensus-based guidelines, which, as a lot of you will know, and a lot of professional societies will have nuanced guidelines, and they really did come together in 2012 to have a set of consensus guidelines. No co-testing before 30. And before 30, you should do a PAP every 3 years. You should start screening at 21. This is for average risk people. So if there's any indication of other risks, those are in another group. I'll be focusing on those people that are eligible for routine screening. And then at 30, you can either do a PAP test every 3 years, or you can do co-testing with PAP plus HPV. Generally, as long as you have an established history of screening and no high risk dysplasia in your history, or of course cervical cancer, you can stop at age 65. The most recent sort of nuances, and there were guidelines around before, but in 2020, ACS came out with theirs that actually said, no, we actually don't think co-testing should be the preferred. The preferred really should be this primary HPV testing, and co-testing should be secondary if this can't be implemented. They also pushed the starting age to age 25. As of right now, there are no guidelines that change based on your vaccination status for HPV testing, for HPV vaccination. However, in the future, that may be a new change that comes down based on the differential risk. So I started getting interested in this topic when I was a postdoc at the NCI, and there was this long, robust cohort that actually, observational cohort that built out the evidence for some of these changes in the guidelines. And so I thought it would be an opportunity to look at, okay, we have the data, right? When did this really centralized program actually start to see these changes in shifting from a more short-term toward more long or extended interval? At this point, it wasn't guidelines, but it was guidelines within their organization. And as you can see, it did take even, this is 6 years based on their baseline screening. So they were screened in 2003, and then I had longitudinal data to see if they came back in the next 6 years. You see that slowly but surely, they did get up to, by that baseline screen of 2009, that about 63% were adherent to the extended. We still did see a good chunk of folks that were early screeners, screening less than 3 years, about 16%. And the late screeners sort of stayed in the same group. And so what this sort of showed me is that even in a well-organized population-based health system, this took some time, and we still weren't to that, close to 100% that you would want to see with guidelines. So, this is sort of at the highest level, but this is underlying a lot of the discussions about de-implementation, right? It's not usually that you have such strong evidence that the thing that is continuing to happen, particularly in the space of cancer screening, is so clear cut, right? It's not a danger issue. It is not a safety necessarily issue. There's usually just differences in the benefits and risks, not in all cases, but it's usually not so clear cut that you can just be like, of course you don't want to do that anymore because it's harmful. More, it's that there's a nuance of the likelihood of the benefit and the risk being differential on these two different types of approaches. So this is just sort of to show that the discussion around HPV primary testing and cytology alone, and why there was this sort of shift, and why co-testing actually in itself adds some additional harm without much benefit. But this is still an ongoing conversation towards primary HPV testing. But sort of put that in your brain to think about, might that be the better way that we could approach this de-implementation of extended intervals as we work through our work. So why do we care about overscreening? And some people, reasonably so, will say, "Hey, it's just a PAP, right? Or it's just a visit, right? Like, what's the harm?" And in this case, with screening with PAP, in contrast to, say, for example, other types of even cancer screening, there is a relatively low likelihood that someone is going to have an immediate harm from in a physical way from screening. Most of the time, they get screened, and you may lead to other workup that has some risk of some physical harm. But more often, it's in other areas that we see this potential impact. So overscreening is this idea that you screen more often than is recommended, or outside the age groups, or after some sort of procedure, for example, a hysterectomy, that you no longer really need to be screened for. This can lead to overdiagnosis of false positives or indolent cancers cases that would regress. And of course, at the end, this can all lead to overtreatment, either sort of primary cancer treatment or sort of diagnostic treatment along the way. But the other things that this can sort of lead to, of course, are financial costs to both the health system and the individual. Yes, it is covered by insurance in most cases, but there can be time off from work and other things that may occur. Psychosocial harms associated with having a false positive or concern about what it might mean. Of course, I noted the physical harms that are quite low in this. The likelihood is quite low. But for me, I also think about this as a system level, that these opportunity costs, when you have people that are coming in and being seen and screened more often than might be needed or recommended, that's an opportunity cost to maybe pull in people that aren't up to date with screening, which we know for cervical cancer, it does persist, that people are not up to date. And so if you're, for example, a person that's working 2 jobs, and you call in as many primary care health systems, you call in to get an appointment, and the next one is available in 6 months, and that's in likelihood, for many reasons, but this can be seen as an opportunity cost to really focus on those people that need to get in screened because they're overdue. And there is evidence, and this is always hard to do, but there is evidence that you can continue to increase your likelihood of harms with this more frequent screening at the country level. Okay, so that's the sort of evidence. And when I started at Penn, I was like, okay, well, that was the data from Kaiser. What's going on in a largely decentralized primary care healthcare system that is not integrated with a health plan? So when I got here, I thought, well, okay, I'll do some pilot. I'm a good implementation scientist. I'm going to do some mixed methods. I'm going to understand what's going on. I have a model, and I'm going to think about this. And so I did some interviews with patients and providers, and also looked at the data within our system using EHR data. And what we found from an EHR perspective is that, yes, even at Penn, we are continuing to screen people more frequently than is recommended. And you can see that 62.9 is actually quite similar to where Kaiser was sort of had left off. But that's for us that are being screened too early rather than who are adhering to recommended intervals. So some of the data, the evidence has shown similar path predictors that people that are screened by gynecologists are more likely to be screened more frequently. And then non-Hispanic Black females are actually less likely to be screened early than non-Hispanic white females. And what was surprising that even in 2020, we did see the proportion of people that were being overscreened. The denominator here is important to note that these are people who were screened, not the whole population. So of the people that got screened, the people that are coming back too early actually was a little bit higher in 2020, which was, of course, the pandemic. To me, that sort of inferred that potentially there was people that were more engaged in the system from the start were the ones that were, of course, the ones more likely to come back sooner than later. Okay, so then we did our interviews. We talked to patients, and yes, again, we see strong evidence that the patients that we were talking to thought that you should be screened not only more frequently than is recommended, but annually, which is, of course, hasn't been a guideline for some time, nearly 70%. And when we talk to them, it's this inertia, this notion that they've been doing it for a long time, that they've been educated. It's important to do it every year, right? We did really great implementation work to get this annual PAP, right? And so women who are doing it are like that, I have to do this. And it's hard to switch, right? And so they've also seen these changes in the guidelines, as I noted. And so they just figure, well, this changed once, it changed back. Why do I have to actually follow this one? And they're probably going to come back and have another recommendation. So I'm just going to keep going with what I've been doing because by and large, right, there hasn't been direct harm that these patients are feeling. They also, of course, not surprising, is that it really is important, the relationship with their doctor, so that if their doctor strongly said, you know what, you don't need to come in as often, they'd be okay with it in the vast majority of cases. When we talked about after 65, this was sort of an interesting, some of the same things came up with after 65, distrust in the guidelines, uncertainty about what will come next, why they are changed, and what sort of went into those guidelines. This other notion of like, that part of it is facing your mortality, right? This notion that you stop screening in part is because your life expectancy is shorter than the screening might have a benefit. And that this person very eloquently said, there's this emotional component to that particular guideline. So this idea, that screening inertia, right? We thought, okay, this is where this, without some external force, this is going to keep in perpetual motion. And in its existing state because it's been so successful from a population health perspective. And when we talked to providers, this idea really did resonate. And then some of it was, yes, sure, some providers don't know the guidelines or they don't want to remember them. But the more important thing is that they're just the doing, right? The habit of it is just doing it. And they think that it's just faster sometimes than to walk a patient through all of the things that have changed and why the evidence is now safe to not be screened every year. It's just easier to do the PAP. And this is very reasonable when we think about all the things that our primary care and OB/GYN providers are doing in a short visit. This is a very rational and reasonable view. So we had one patient that sort of said, because of our interview, she had time to digest the information. And she thought, next time I'm going to talk to my provider, and that next time I think I'll be more comfortable. So we had a notion that actually we do think it can be changed, but how we might need to change it has to be multi-level. So we did one more step before we started our project was we tested some messaging and in implementation science, but in particular in behavioral economics, there's a notion of sort of frame messaging. You frame something as the gain you will get from doing something or the loss you will get or harm, risk you will get from doing something. And so we did some preliminary testing of the messaging. And we did see that the messaging really did help with knowledge and perceived effectiveness of in particular, HPV testing. And there was some wiggle room on their likelihood to intentions to be screened annually, but not really what we were hoping. We also didn't see any significant interaction by message framing. So when we were thinking about the next step, right, we did this robust many years of preliminary contextual data, testing our assumptions. I'm not sure quite what's going on with my slide, but that's okay. We drew from a body of literature, growing literature and expertise, particularly at Penn, that we could use these low touch, large spread, pragmatic approaches, nudge strategies informed by behavioral economics to really roll this out across the health system. And we could do this by changing different components of our system. So it's an individually focused intervention with regard to sort of what you think is going on and why people are doing what they're doing, but we roll it out at the system to try to see that low touch, widespread change in a pretty rapid approach. So when we were thinking through the strategies, and I'm going to go through how each of these have really been challenging, we thought that these three green ones, framed information, prompting intentions, and changing the option related effort were both going to be effective and feasible in our system. So theory, check. And I'm going to show you what our theory was. We have a theory-driven intervention, robust contextual inquiry, check. Pilot testing, check. We're ready to go. We've done our work, and we're going to roll out our R1. We've used our approaches with behavioral economics for other things when we're implementing, and we're doing so in many different studies. So we have really good assumptions that this will work. It also has worked in other de-implementation approaches. So we were certain that this was an approach that we should use and that it was going to work. So where we started, just high level, it took, first of all, 4 submissions to get this funded. I just want to lay that out there, that getting de-implementation science funded is a bear. But it took 4 submissions. So we were really thought about this for many, many years. And we were doing a pragmatic trial that is a factorial trial. You'll see sort of highest level that we're going to have a patient nudge, theory-based messaging with ask, share, know, which is a priming for communication strategy that's been shown in other work. And then what we had proposed was point of care reminders in the EHR to alert clinicians when patients are not due for screening. So these are patients that are up to date for screening and are scheduled for a next screening appointment. That was the point in which we thought we could intervene. Part of this reason of the timing was because NIH grants, of course, are only 5 years. So you could design a study if it was 10 years long, by which you intervene at the last visit of it that they were screened, and then you wait to see if they come back. But that, of course, requires that you have at least 5 years follow-up. And so we had to think through how we could measure and test this in the time constraints of an R01. We have a bunch of secondary de-implementation outcomes, and we also have a robust qualitative contextual mechanisms aim that I'm not going to talk about, largely because we haven't even got there or even close to there, because the trial has been so challenging. So our theory-based, so again, we took all that knowledge and our testing and we applied it with the COMBI, which many of you may know, the capability, opportunity, behavior wheel, motivation model. We modeled that. We thought it was a nice fit with behavioral economics. We took our strategies, we identified our targets of behaviors and what we were going to measure, and then ultimately, hopefully, we were going to have behavior change and decrease rates of overscreening. And then we have our combination with our determinists to understand what works and what doesn't work as our second aim. All right, so that's where we started. We're at the beginning of year 3. So this is the learning that we've achieved. So the first lesson, and there's a lot of things I'm sort of going to skip over the course of the last 2 years, but the sort of where we are now and the major things that we've learned and why this has been so challenging is, so there's that nudged ladder again. And you'll see at the top, which we did not propose in our work, that the most effective strategy and the less restrictive on individual choice that has been shown to work in other de-implementation work is actually you change a default option in an EHR or otherwise, so that the default option is the thing you want them to do. And then they would have to have extra energy and effort and motivation and all the things, knowledge, to then change over to the thing that they have been doing. And so you're sort of shifting the status quo to what you want to do. This has been, again, proven to be shown in EHR-based study as a good way to approach the implementation. And it initially was our thought that we might be able to do it. However, from all the years of the sort of working up, which was, again, 10 years after the guidelines were implemented, our system was pretty much set that they were not going to change the default option anytime soon. And that where their default option was on the 3 years. And there's a lot of good thinking on why that was, because again, 3 years, you can get screened every 3 years if you use PAP alone. And so they sort of thought, right, if you go to 5 years, it's going to be harder then to get people down who are just getting the PAP, and we're going to have people that are actually late. And so we learned through our engagement prior to the work that changing this option was not an option A for our study, and it was not likely to change anytime soon. Well, short period before the study began, those 4 submissions probably helped. The default did change to 5 years, which is actually wonderful for guidelines. And because the vast majority of people that are being screened are co-tested, so again, that 5-year recommended interval, great for guidelines, not great for our study. But the lesson learned here, of course, is systems don't change until all of a sudden they do. But the good news was, right, we had actually not even said we were going to do this, right? So if this had been our main strategy, we could no longer do that strategy because it was, or randomized strategy, because it was already in place. And so we had proposed, again, sorry, that red circle should be 1 up, to change option-related effort through disrupting the status quo behavior at the time of care. So we thought, okay, this doesn't change too much. Yes, we're going to have probably a lower proportion of people that are being overscreened because of the system level change. But we did our work, and we looked in our data, and we refined our algorithm, and we did find that, yes, there are new data elements. Yes, the order set is more complex, but it still seems to be that there are people, a good amount of people being overscreened. And our approach at this point of care seems like a feasible and accurate way to do it. We also did, again, we had done a lot of contextual inquiry on pathways and what's going on and how people make orders. We did some very brief sort of updates to make sure that nothing major had changed after we got funded. And yes, there is diversity in the workflow, particularly between our primary care, family medicine, internal medicine, and our OB/GYN specialty practices. But that, by and large, our approach was still feasible. We were just going to have to tweak things a little bit based on their clinical processes. Our final step after this work was to pull together. We have a board of wonderful, engaged clinical partners, and we sort of presented all that we had found in our proposal for this best practice alert at the time of ordering the PAP test. So the meeting, I think, was Rachel, I think, was there. It was an hour long, and towards the end, they had been giving us feedback on the process, and overall, everyone sort of seemed aligned. There were small things we needed to tweak. But as the meeting progressed, 1 and then 2, and then several of our very engaged clinicians noted that, sometimes, if not often, depending on probably the specialty in the practice, they actually don't even order the screening test in the EHR, which of course would then trigger this point of care alert until after they've done the PAP. And I emphasize that they're doing this for good reason. They do this because to order it while you're with the patient sort of breaks that continuity in communication. I think there was some discussion of whether or not this was supposed to be done, but either way, for us to propose a order-based alert when we learned that they were actually ordering it after they engaged the behavior was not going to set the study up well to work. So it might change future behavior, but again, because of that restriction of the timing on which we have to measure our outcome, it was going to be too late for us to observe a change. And so our lesson learned of this, of course, is timing, both from a study perspective, but also when you're intervening in care practice, is everything. So the last sort of, and there's many other, but the last bucket of lesson we learned was that there's emphasizing there is something to do is an important approach. And so again, I'll say our third right there, our third approach we were going to do from a patient perspective was providing this framed information about evidence-based practice, so about screening. And at the core of sort of behavioral economics is prospect theory and other, and it's been, this is behavioral economics at the very basic. There's a lot of nuance to it. But that there's a sort of an idea that when you frame things differently, again, gain or loss, that this will change people's behavior. And it has shown in other nudge studies to be successful. So for D implementation, we struggle a little bit sort of conceptually, is that we actually we want someone to not do something. So how do you frame a gain frame in particular when you're thinking about someone not doing something? So using a loss frame for us, at least conceptually, that was more straightforward. We wanted to emphasize, of course, the harms of overscreening. That conceptually was more straightforward. But when we tried to figure out what is a gain frame message in a D implementation study, are you emphasizing the benefit of not doing the thing you don't want them to do? Or are you emphasizing the benefit of actually adhering to the guidelines? And so it still is a pro-behavior message that you're sending to patients. And so we thought, we did do that other prior work with our messaging, but it was a longer messaging. And because we were sort of struggling with this notion, we thought that we should do more cognitive interviews. The other thing that we wanted to do is make sure that we had a more diverse group of patients that were giving us feedback. So we made sure that our sample was at least 50% African-American patients. And in our system, that is by large the most historically minoritized population that we care for. And so we sort of have to use those two buckets when we're thinking about sample size for qualitative work. So just as sort of highest level, I want to give you a taste of some of what we came up with for our loss frame messages. And you'll see that this again, the loss is right. What's the emphasis of on what you'll lose if you do the behavior? Here, the behavior again is over screening. So you might wonder if these screening tests save lives. You might wonder if screening tests save lives. Isn't it better for people to get tested more often and with more tests? For most people, screening more often than recommended might hurt you more than help you. Screening more often than recommended does not increase your chances of surviving cervical cancer and can result in unnecessary tests, procedures, and costs. On the flip side, the gain frame, again, we were sort of struggling. We thought, what can we come up with that's sort of a gain of not doing the thing over screening? And so this is what we drafted. Cervical cancer screening can save your life, but did you know that being screened too often can also lead to harms with no added survival benefit? Depending on your past results, you may be able to skip screening this year. So that's sort of the gain. There are reasons people get screened, but there is sometimes a notion that women really want to continue screening. And it's really generally in our data, and I think in my experience, is not something that women really love doing. It's just something we think that is really important to do for our health. The other thing that we added was that this ask, share, know, is that we were giving them something, a tool, 3 questions you can help to start the conversation. So we did want to emphasize, of course, that talking to their doctor is important in all the messaging. We had like 7 or 8 other messaging. I just wanted to sort of give you an example, and we tested them all with the individuals. So we learned a lot of things, but these are sort of 2 quotes that I wanted to sort of share. Particularly with regard to the loss frame. So the first quote says, again, my thing is and this patient sort of kept bringing this up, what are the unnecessary tests and procedures that comes out that, that's the emphasis, but I don't know what they are. And then do you say in one part being screened too often can lead to harms with no added survival benefits? So that sort of notion of that it's not going to help you more to get screened more. Now that's something that at least stated, but I still like to know what the harms are. And we heard from many people, particularly people that have been screening for many years, that, they just don't agree with the guidelines always. And for them, it was not a problem to be going every year, and that they were going to continue doing that until they were physically able to do it. This is particularly in relationship to that notion that you can stop screening with a normal history at age 65. So what we sort of learned in this, and this is, we did think about, in our proposal, of course, there are many good reasons why people continue to do continue to be screened more often than is recommended, both from a clinician and a provider and from a system perspective. There are very good reasons. People generally have good reasons on why they're doing this. But that, when we were thinking about just removal as a de-implementation strategy, that when we started to talk to people, this didn't seem like it was going to move the needle in the way that we were hoping. And so we learned that, even if we're not going to replace, because there's not really something we can replace, again, unless we're going to do the primary HPV testing, which we can talk about, or substituting, we really are just reducing or removing this more frequent behavior. We learned that emphasizing the positive of doing something, even if it's not another evidence-based practice, was much better received and actionable. So the something here for us was that talking to your provider, right? That was the something that we thought we could give patients, and we're going to test. That might be something that we focus on promoting that behavior, and hopefully then we'll get to the behavior that we're trying to do, which is, of course, decrease overuse of screening. This also may help with mistrust of guidelines, medical systems, that it's more of an empowerment strategy rather than a removement strategy from sort of a pragmatic approach. Two things I want to note that I'm not going to talk too much about, but we saw very substantial differences in generations about both behavior and response to screening, where generally, again, the patterns are that patients that are older and been screening for a long time, they really are invested in this behavior and responded to some of these messages in a much more strong that, they just don't want to stop screening and nothing's going to make them change. Younger generations just starting to screen didn't have as much knowledge or habitual behavior, seemed to be more receptive. We also tested and got direct feedback on gender inclusive language, which in this case, I think the recommended language is people with cervixes, or a person with a cervix. And while we and the group people we talked to all recognize the importance of gender inclusive language, that sort of language actually was was offensive to some people actually, but also very non-motivating for most. And so we're sort of, I think, going to take approach that we're going to say people, because we really haven't been able to come up with great language that is inclusive and motivating without excluding certain people. So those are a lot of things we learned on the messaging. But the big one is that really we need to still give them something. And we, from a behavioral science, it's much more, it's easier to emphasize the something that they're going to do that hopefully will reduce the other thing along the way. Okay, so to sort of wrap it up, that, again, we're still in it. So more lessons are definitely going to come. And I really look forward to hearing thoughts and comments. But, that as I started, de-implementation work is hard, but it's really, really important. And I think it's increasingly important when we're thinking about some of the strategies we use across our studies, where we're just keep loading things on to clinicians and providers, and we're not taking anything off. So it's not only from a perspective of the evidence changing, it's from a perspective of burden, that we need to figure out how to, when we add on, that we also remove or reduce to make sure that we reduce burnout and, quality of work and life, and of course, health outcomes for our patients. So some key takeaways. So this is both from a research perspective and from a people and clinician perspective. A lot of what we do is driven by passion and commitment in our work, in our life, whatever it may be. And it's just generally easier to get excited about helping people to do something that will help them than to get them to stop doing something that is not inherently bad for them, right? Screening is good for you, just not screening so much. And so it is an exhausting actually work to do from a research perspective in comparison to some of the work I do, where we really are trying to get people something that we know is going to help them. This is a sort of a shifting. But what has helped for me is that the principle, right, can be applied to de-implementation. We are going to help them to do something, right? You just have to change what that something is in the context. So this model of substitution and replacement, and there's some great work that's been led by Wynn Norton and others, and sort of conceptualizing this, is useful, even if it's not about the thing, right? You're not substituting a thing, you're substituting another behavior, and that can be motivating for both researchers and the patients themselves. The other evidence is constantly changing. Experience is real. Emotions are important behavioral drivers, and it is very rational, whatever you want to think about that term. that people continue to do things that are not evidence-based. And this is sort of a signal to behavioral economics that is built on this idea that people do behave in irrational ways, but it's predictable, right? So I do think that, and it's much more nuanced than I'm making it from a concept of behavioral economics, but I do think thinking about in our own work, how can we advance this idea of a nudge, right? Trying to make a system that reduces friction and makes people easier to do the right thing. How can we really better incorporate this notion of experiential emotion as drivers in a way that's still aligned with some of the principles that have worked in other settings? Cancer screening, and likely any implementation, there's two any's there, always comes with risks, or we sometimes say unintended consequences. But public knowledge and even researcher knowledge of these is really not well known. So I think as a field, it's really important, whether you're doing implementation or de-implementation or some other vein, that it's important to consider, measure, and report on these. And so it becomes more normalized, right? That when we do something that's a preventative action, there is always things to consider that may be negative, and that balance may shift at some point, and we may have to de-implement. And last but certainly not least, is that evidence is not equal, and guideline medical trust is very reasonable. In this work, I'm not emphasizing it because I'm more talking about all the failures, but when we talk to people, right, the evidence that we're giving to people about the guidelines, it's true. It's not always been based on people like them, whatever that may be, right? Even older people, right? Some of the evidence. And so we as implementation scientists, I think, have an opportunity to continue to work to actually build our evidence of these evidence-based practice and make sure that we're really being inclusive in not only the strategies, but the evidence itself. And with that, I will pull down my screen so I can see you all, I think.